Hi everyone, and welcome to our Fertility Network UK webinar this evening. We're joined by Professor Tim Child from TFP Oxford Fertility, and Tim is going to be answering your questions about preparing for treatment. We're going to be recording the webinar, so you can watch this online afterwards if you want. The webinars are all recorded onto our YouTube channel, but they're available through the webinars page on our website, so you can catch it there. If you want to ask any questions during the webinar, you can put them in the Q&A box, which you can see just on the bottom there. Don't worry, anything that you ask is completely anonymous. We won't read out your name, we'll just read out your question. And if you can try to keep the questions as general as you can so that they might be more relevant to other people as well as you, that will be really helpful. We've had quite a lot of questions sent in advance already, and we're going to try to get through as many of those as we can this evening. We might not get to everyone's question, I'm afraid, but we'll get through as many as we can. So Tim, I think we might as well make a start now. I mean, the first thing that I wanted to ask you was, do you think there is much that people can actually do to make a difference to the outcome of their treatment?
Thanks, Kate. It's a very good question to start off with. I mean, certainly general lifestyle things are important. They are related to the chances of conception, lowering the risk of miscarriage and the chance of having a healthy live birth. So certainly there are things that can be done. I think I'm sure we'll speak more about this in the next while. Optimizing the diet, looking at your weight, so optimizing weight, body mass index, keeping generally fit, any underlying health conditions, trying to get those under control. There's vitamins, there's all sorts of different things that can be done, but I don't want to talk and then in 5 minutes cover everything we're going to talk about. So we'll see where we go.
One thing I think a lot of people wonder is, there might be some people here who are starting treatment in maybe a few months and some who are starting next week. When's too late? How soon do you have to do it to make a difference?
Well, I suppose it's never too late, to be fair. I mean, certainly things like smoking. So stopping smoking is very, very important. And sometimes patients will say, well, I don't smoke a lot. How little is okay? And with a lot of this stuff, we don't know the answer. And also, we don't know for how long people should stop smoking. So if someone asks for that question, I'd always say, well, ideally, if you can stop today, if that gives you 6 months or 6 days before treatment, then that's better than smoking into treatment. So I think there's no strict rule on that. Unsurprisingly, the longer the gap before treatment that you're stopping whatever it is or sorting things out, the better.
We did have one other question specifically related to smoking, actually, which I might ask you now, as you just mentioned that, which was about passive smoking. I mean, some people are sort of giving up smoking themselves, but if they're going to be in smoky environments, is that dangerous too?
I mean, it's very interesting on that one. So a number of years ago, when I was involved with the CCGs are the GP funding agencies that fund fertility treatments. After the 2013 NICE guidelines that you and I are both involved with, Kate, there was a discussion in there about the risks of women smoking who were heading into fertility treatment. And the CCGs at the time were wondering about passive smoke, and they wanted to look at the effects of passive smoke on a woman's fertility and also on a man's sperm as well. So there are links between men smoking and their sperm quality. Whether women being exposed to passive smoke, either from a partner or from it's not so common now as a workplace, but being out and about has an effect on fertility is very, very hard to say. I mean, I think it's one of these things where if someone is out and for a few days, wherever you are, you go out somewhere and there's smoke around, that's not going to cause a problem at all. I think we need to be really clear that just a bit of exposure to things is not going to cause a problem. So it's not something I get worried about. If someone was working in a place where every day it was very, very smoky, then that is not ideal, because that's going to be similar to smoking yourself.
We've also had a lot of questions, unsurprisingly, about alcohol. And I think one of the things people really want to know is, do you have to stop drinking completely? Do both partners have to stop drinking completely? Or if you're going to a party or whatever, would a drink here and there make a difference?
So usually when I'm asked that in a consultation by one of the partners, if there's two partners there, it's a very, very loaded question, because I can tell straight away that there's been previous discussions, in inverted commas, between the partners about this, usually with differing views on it. So I always have to be very careful, Kate, and how I frame the answer to this one. So I think different specialists will have different views on this, which generally will tell you that there's no clear evidence one way or the other. Obviously, excessive drinking is bad. Moderate drinking is probably also not a great idea. Whether a small amount of alcohol is better, whether no alcohol is better than a small amount of alcohol, I guess is the crux of the question. My view would be that having, a few glasses of wine here or there, if that's something that helps you relax after a stressful day at work or home, whatever is going on, that is not going to cause a problem in the run-up to fertility treatment at all. That would be my view on it. You will find specialists who say you should have zero approach to alcohol, which I guess is the absolute safest approach, but the evidence that zero is better than 2 or 3 glasses of wine a week, I'm not aware of any evidence saying that. So I wouldn't be worried about it at all. Just a couple of glasses of wine a week is fine.
We had a question specifically relating to male partners and how long in advance they should stop drinking. And, I think you've sort of answered some of that by saying you could have a few drinks, but if someone was going to drink maybe a bit more than that because of a special occasion or a holiday or whatever, how long in advance should they, how long will they have before it makes a difference to their sperm, I suppose is what I'm asking.
Yeah, so sperm production takes about 70 days. So it's about 2 months for it is a cycle of sperm production. But again, it's not that having some drinks, a couple of times during that 70 days is going to mean that the sperm is not working at all. I think it's obvious that conceptions can occur after too much alcohol has been drunk. So it's not that excessive alcohol stops conceptions happening. That's certainly not the case. So I think certainly for men, the 2 or 3 months before treatment, because that sperm is going to be produced during that time, it absolutely is a time to be sensible about things. Probably going out and binge drinking during that time would not be ideal. And may have a detrimental effect. But again, I'm, as you can probably tell, I'm a bit relaxed about some of this stuff. And I think it's very easy for doctors or specialists to say, cut everything out. And I always think that the fact that people are in a situation where they are even having to discuss their fertility with a third party is a pretty stressful situation to be in. Having someone then say, cut out everything that you enjoy, when there's not really a lot of evidence to cut everything out, maybe just makes things even worse. So I think the last thing to say on that is with a lot of these things, and sometimes people will say, well, I'm in the couple of weeks before treatment, and I'll say, look, if you're going to do something, and if your treatment doesn't work, will you look back and think, I wish I hadn't done that? If you sort of feel comfortable that, no, I don't think what I'm going to do, whether go out and have a few glasses of wine, is going to make any difference to treatment because I believe what I've been told by the doctor, it's absolutely fine. But if you think it's really going to be stuck in your head that doing that was a really stupid thing to have done, then don't do it in the first place.
I think that's a really important point actually to bear in mind, isn't it? Because a lot of it is around kind of people blaming themselves afterwards. And coming back to what you were just saying about stress, we've had quite a few questions about stress and people really worried about stress. And I think in a way, the more worried you get about stress, the more stressed you get. I mean, does it have an outcome on treatment? And would you recommend people do things specifically to try to reduce stress in the run up to treatment?
Very, very common question. And I think an issue is the definition of what stress is. So, stress for one person will be their reason to get up and go, and what keeps them going for another person. And some people thrive on stress. Some people, it just wears them down and can be very detrimental. So the difficulty is defining what stress is. That therefore makes studies very, very difficult, because you can try and do studies where you measure levels of adrenaline and other blood chemicals to work out levels of stress, or you can do psychological testing, or all sorts of different things. There haven't really been any studies showing that different stress levels absolutely will, for instance, stop an embryo implanting, which to me makes sense. I mean, in the end, if an embryo has been made either naturally with the egg and sperm meeting in the fallopian tube, or in an IVF laboratory with an embryo being put back into the uterus, I can't really understand how the woman or the partner being stressed is going to stop the physical nature of that embryo implanting. The way that stress, I think, really can be detrimental is for people getting pregnant naturally if it's affecting the frequency of intercourse. So if people are feeling so worn down or maybe depressed by the situation, have lost their libido, then of course that will be reducing the chances of getting pregnant naturally. The other bad thing about stress is how it affects how people react to treatment not working. So if someone's stress, whatever stress means to them, means that it's making it even more difficult for them to cope when treatment cycles don't work, and maybe even stops them going on to have further treatment cycles, then stress is then potentially stopping them getting pregnant with the next cycle that potentially could work. Now, going on to the last bit of your question about whether things should be done to reduce stress, then for the reasons that I've said, where stress could be a bad thing if it's affecting frequency of intercourse or how people feel during treatment or cope with a failed cycle or a miscarriage, then absolutely reducing stress can help. Now, maybe for some people, that will be by going out for a run. For others, it will be with meeting up with friends. For others, it might be acupuncture. For others, reflexology. Whatever it is, if that is helping you cope with the situation and reduce stress, then that's a positive outcome. Whether it improves the chances of having a baby might be questionable, but if it helps you psychologically and your relationship or your work, whatever it might be, then that's a positive outcome.
We do get quite a lot of questions about complementary therapy, because I think quite a lot of people sort of feel now that they probably need to do some of these things. I mean, what do you think in terms of the evidence? I mean, do you think it actually makes a difference if people do like acupuncture or whatever, or do you think that the evidence isn't there yet for any complementary therapies?
The approach that I take is to try and be as evidence-based as possible. So where studies have been done showing that something doesn't work, we have to take that into account. And obviously, if studies show that things do work, that is equally important. The problem is in lots of these areas, the studies just haven't been done. So we can't really say one way or the other. Now, interestingly, acupuncture has been around, well, it has been around for a long time from China, but also it has been studied quite significantly. And the studies, I think, fairly convincingly show that acupuncture during IVF does not increase the chance of an embryo implanting. So it does not increase the live birth rate. I worked for a while in clinics in China, in Shanghai, and in China, where even now in traditional Chinese medicine is still very widely used in China, they did not mix at all IVF with acupuncture. Never did it. When I told them at my clinic in Oxford, patients were having acupuncture with IVF, my Chinese colleagues were saying, well, why would you do that? That just doesn't make sense at all. But again, an increased live birth rate is not the only important outcome. So if I'm asked about acupuncture by a patient, I will say, well, if you feel better for it, if you feel it's giving you control, if you feel that half an hour to an hour you're spending with the acupuncturist is a positive thing for you, absolutely. And if you don't mind having acupuncture, absolutely go for it. I don't think it will increase the chances of live birth. Others might have a different opinion, but that's not the only important outcome. And I think the same is true for reflexology and all those a number of the other type of things that you've mentioned. I personally don't think they increase the live birth rate, but that's not the only outcome which is important.
That's a really good point. Thanks. The other thing we've had a huge number of questions about is about supplements. Now, we know that everyone should be taking folic acid, but people are taking various other things. I've had questions about prenatal vitamins, vitamin D, magnesium, calcium, omega-3, CoQ10, DHEA. I mean, what is your view on what else people should take? Is it good to take extra things?
Again, really, these are very good questions that have been coming in, and these are ones that we are asked day in, day out in clinic. So folic acid and vitamin D are important for women. For most women, to answer you, that's probably enough. Women with a fairly, or men or women with a fairly sort of normal diet, then the food that we eat is fortified with so much stuff nowadays. But if you're eating a healthy diet, and I think if I just mention diet first, often people speak about the sort of Mediterranean type diet as being good for fertility. What that really means is less processed food. So when you actually look at the different Mediterranean diets, it's less processed food, it's more freshly cooked food, which again, when you look at weight loss, is really the cornerstone of weight loss. When you look at if men have, we might come on to sperm DNA fragmentation tests, but those sorts of tests, the Mediterranean type diet, less processed food, is thought to help sperm DNA frag results. Now, in terms of supplements, then for women, the folic acid, which reduces the risk of spina bifida, it does not increase the chance of getting pregnant. Folic acid is there to reduce serious complications that can happen to babies during pregnancy. Likewise with vitamin D, it helps reduce pregnancy complications. Now, whether you should take things on top of that, based on studies, is probably fairly questionable, but it's not going to do any harm. So I would say to anyone, I think things like Pregnacare, that sort of stuff that you can get from any sort of chemist, it's got vitamin D in it, it's got folic acid, it's also going to have the right amount of calcium and zinc and all that other sort of stuff. So Well Man, Well Woman, Pregnacare, those sorts of things are going to have all of the normal type vitamins. The next question is whether you need to go further than that with the more fertility focused ones that you mentioned. So coenzyme Q10, sometimes called CoQ10, DHEA, they would be two very common ones that are brought up. And the answer is no one knows. So CoQ10 you can buy from Holland and Barrett, 400 milligrams a day or something of that. There are lots of claims made for it improving egg quality and improving fertility, but because it's a vitamin, the people making it can claim anything they like. If it was a drug, it would be illegal for those claims to be made, but vitamins aren't regulated in the same way. So you get just wild, unsubstantiated claims. So CoQ10 is very widely used, supposedly for egg quality. I've not seen a single study showing it improves egg quality or embryo quality. DHEA is something that you generally can't get hold of in the UK. So normally people buy it in from probably American health food shops online. And DHEA is often used for women with low ovarian reserve, so low numbers of eggs in the ovaries. It does appear during IVF to potentially increase the number of follicles that women have during IVF in some women, but whether that increases the number of embryos is questionable because the studies just haven't been done. There are some of the fertility supplement manufacturers that have made preparations that contain all this sort of stuff. So Proxseed would be one of them, Impril. There's a few different companies out there making it, and they tend to sort of bundle all these things together. They obviously cost more than Pregnacare. Whether they're any better, I think it's hard to say. But none of them are going to do any harm, I suppose, which is very important.
Yeah, we did have a question about that actually, whether you could take too many supplements. I mean, is there a risk that people could end up taking too many, and could that have a detrimental effect?
I think there is a risk. So I don't think there's a risk if you're buying stuff from a chemist, so Pregnacare and whatever. There's not a risk with that, or Proxy or Impril or these other ones, Fertilix, these other ones like that have been manufactured, and you just take one sachet a day of whatever it is. I think also if someone who knows about these things, if that's a very well qualified nutritionalist is giving you advice on it, I would be pretty confident that you're not going to be taking too much. I think the danger is if you just start reading things off the internet from someone who you don't know who they are, and you start buying 5,000 international units of vitamin, whatever it is, and making up your own stuff. And I always remember I did my fellowship training in Canada, in Montreal, and I always remember I was called down to the clinic once by the endocrine, so the hormone team, who had a patient, a woman who was trying to get pregnant, who'd come in feeling unwell, and she had bought some traditional Chinese medicine herself. She was a white Canadian, not from a Chinese background, but she'd done a research online, and she bought some stuff. And the problem with a lot of these things, particularly the traditional Chinese medicine, the herbal stuff, is the strength of the chemicals in it is obviously variable because it's just made from leaves and stuff. And whatever she was taking had sent her into thyroid overload. And her heart rate was like 150. She was feeling unwell because she was taking, in her mind, natural medicines. But natural medicines can have all sorts of stuff in them. So I think you need to be careful.
And is that particularly with Chinese herbs as well? Because someone had asked a question earlier about Chinese herbs. I mean, do you think that one should perhaps err on the side of caution there, or only see a specialist who actually knows what they're doing rather than buying them online?
It's I think this probably comes back to the acupuncture during IVF thing, and it's difficult if you start mixing traditional medicine and modern medicine together. So what we don't know. So again, if you're buying things from a chemist, then you know what's in it, you know the strength of it, and the doctor who the specialist that you're seeing can, if you ask them, can give you a judgment on whether that is too much vitamin C or E, because there are national guidelines as to how much you should be taking in maximum levels. As soon as you start taking things that have been made in a back room somewhere with sort of mulching up leaves and whatever, and that's what I saw happening in the hospitals in China I worked in. You've no idea what the strength of them are. You don't know what's in it. And very importantly, you don't know how it interacts with the IVF drugs or the fertility drugs that you might be given. So most clinics would advise that you don't take those sorts of things where we don't know what the strength is or how much is in it and even what chemicals are in there whilst you're being given drugs. But again, that is something you really should speak to your doctor looking after you about.
Great, thanks. We've had quite a few questions about diet, and as I'm sure you know, there are a lot of ideas about things that people should be doing, like pineapple core and like the McDonald's fries after embryo transfer. I mean, are any of them right? I'm sure you know about most of them. I mean, do you think like the Brazil nuts and the pineapple core, do they make a
Yeah.
difference?
Well, I mean, I always when I'm asked these things, I always feel as though I'm probably giving really boring, depressing answers because I'm not sort of going, yeah, do that, go to McDonald's and have fries after an embryo transfer or after having sex or whatever. And so I think for a lot of these things, I just don't know where the initial information came from that suggested it was a good idea. That having, I guess probably for McDonald's fries, it probably came from something that was quite popular a few years ago, which was a fat infusion, an intralipid infusion, and it was quite widely used. It's not used so much now. Intralipid is a fat infusion that was given into some patients' veins if they'd had tests showing higher levels of natural killer cells and things like that. Now, quite rightly, in my view, there's been a move away from natural killer or NK testing in the UK. And therefore, I can't remember the last time a patient actually asked me to have intralipids. It's probably a year or two ago. It used to be asked every week. So that is less common now, quite rightly. And I wonder whether the McDonald's fries, because the fat came from that, I don't know. Again, the pineapple, there's one of the main chemicals in pineapples was shown in, I think, in mice studies to be good for fertility, in mice eggs or something. And then there's been a huge leap of faith to think, well, maybe pineapples are good for that as well. I'm not aware of any studies where actually people have eaten, half the patients have been told to eat pineapple, half have been told to eat apples or something else. And then you've looked to see, are more babies born after pineapples? I don't think that study's been done, and it probably never will be done. But it's not going to cause any harm. So again, it comes back to what we said before. And if you hate pineapples, I would say don't eat pineapples for fertility. If you actually quite like them or you don't mind them, it's not going to do any harm. And the same thing would be true with Brazil nuts as well. These things aren't going to do any harm at all. Whether they help, though, I think is questionable. But if you feel it's a positive thing that you're doing, that's another good thing.
Yeah. Okay. What about caffeine?
So caffeine's an interesting one because excess caffeine has been linked to an increased risk of early miscarriage. So there are data showing, and again, obviously caffeine is, so unlike pineapple, and I've never, I like pineapple. I've never eaten so much pineapple that I've actually felt the effects from eating it. Whereas all of us will know that having a double espresso at 10 o'clock, unless you're having lots of caffeine, you're going to have a pretty quick effect from that. So we know that caffeine is a drug like alcohol that does have effects. So, alcohol during pregnancy is not a good idea. We know that's true. Caffeine during fertility treatment, caffeine in early pregnancy, excessive caffeine in early pregnancy has been linked to a higher risk of miscarriage, but you actually need to take quite a lot. Now, probably going back, 15, 20 years ago when we were all just drinking Nescafe, it wasn't really an issue because you'd be pretty hard pressed to be drinking high amounts of caffeine. But now with the Starbucks on every corner and Nespresso machines in lots of people's kitchens, you can get through a lot of caffeine very, very quickly. So I would generally advise if patients are liking the taste of coffee and they, or tea, and you're drinking quite a lot of it, perhaps do consider switching to caffeine-free, which the better brands, you'd probably be hard pressed to tell the difference.
That's good advice. Thank you. You did mention earlier sperm DNA fragmentation, and I just wondered, what is your view on that? I mean, is it a test that people should be having before they have treatment?
So, a problem with fertility testing is that there's very little testing that it is generally done or can be done on the male side, and that has led, therefore, to laboratories sort of really in response to probably sometimes patients saying, well, we want more testing, and also obviously also clinics. So A normal sperm test is looking at things like the count, which is obvious, just the number of sperm, the motility, which is the percentage swimming forward, and the volume. So the count, motility, and volume are the three main things in a semen analysis. But the fourth thing that people look at is the morphology. The morphology is the shape of the sperm. It's not a very useful test. So many men will be told they've got too many sperm of an abnormal shape. And I would say to them, it's a pretty useless test, actually, that fourth one. It's really count, motility, and volume are the main ones. And that's sort of it. So that has led on to think, well, what further testing can be done? And what can be done is sperm can be sent off to special laboratories. So this is not usually available in a fertility clinic. This sperm has to be sent away to 2 or 3 labs in the country that are doing sperm DNA fragmentation. And what they do is there's 4 or 5 different ways that the test can be done. Essentially, they're looking to see whether the nucleus, where the DNA is in the head of the sperm, is nice and condensed, or is it a bit fragmented? And then they put the sperm through different chemicals and they measure the levels of sperm DNA fragmentation. There are a number of problems with the test, though. One is that, as I said, there's 4 or 5 different ways of doing a sperm DNA frag test, all of which give completely different answers. And there's no internationally or even nationally agreed best way of doing it, unlike if you have an AMH test, blood test for your ovarian reserve. There are very clear guidelines, international guidelines, as the best way of doing it. Sperm DNA frag, there aren't. So there's no one way of doing it. Secondly, the studies that have been done are quite conflicting and aren't great quality. And most of them are what's called retrospective, which means that what happens is a clinic will test 300 men's sperm DNA frag, and they'll then look back to see, well, what were the embryos like that couple produced previously? And then you think, well, if we found that there were high levels of sperm DNA frag, which is thought to be bad, and the embryo quality wasn't great, maybe the high sperm DNA frag has led to the poorer embryo quality. But obviously, it could be due to other things. It could be due to female age, lifestyle, all sorts of other things as well. So it's not been absolutely accepted that there's a definite link between the sperm DNA frag result and IVF outcome. That's the second problem. First problem, no internationally agreed test. Second, no proven link. And the third major problem is it's not been proven that treating sperm DNA frag improves outcome. So if you get an abnormal sperm DNA frag back, what will happen will be the clinic will talk to the man about improving lifestyle, so optimizing body mass index, which I started off by saying is a good thing. So definitely that's important. Cutting down or stopping alcohol, cutting down or stopping caffeine, making sure the testes are cool, taking some multivitamins, the sort that we spoke about as well, and eating less processed foods, so sort of Mediterranean type diet. Now, all of those things we've spoken about are things that are a pretty good idea anyway for general healthy living. In the IVF lab, if you have a man with a raised sperm DNA frag, often what they'll do is they'll suggest, even if the sperm's got normal count and motility, they might suggest doing ICSI, which is when you inject the sperm into the egg, rather than conventional IVF, which is when you just mix the eggs and the sperm together. And there were some retrospective, so backward-looking studies suggesting that for men with raised sperm DNA frag, if you do ICSI, that can help the outcome. But all of this at the moment, I have to say, is fairly sort of maybe. And what we're waiting for is a really good study proving the best way of doing sperm DNA frag, proving that there's a link between DNA frag and outcome, and proving that you can do something about it. And at the moment, all 3 of those things aren't in place. So I think it's something to consider for men. It's something to consider, but I would always take the result with a bit of a pinch of salt.
And those lifestyle things that you were mentioning earlier for men, I mean, would they go for all men anyway before treatment? I mean, would you say that those things are always a good idea?
I think so. I think for all of us, cutting down on processed food and eating more, it doesn't mean that you can never have that McDonald's burger and fries and whatever, but I think just a general move, if you're trying to optimize things, if you're having fertility problems anyway, and you're thinking, well, what can you do for yourselves before starting potentially to shell out lots of money and going through lots of cycles of treatment, whatever treatment that might be, then I think there are things that can be done. So less processed food, more freshly cooked food. I always remember at medical school, there was, all those decades ago, there was something about, that one of the sayings was for diet, just buy stuff from the butcher, the greengrocer, the whatever. You don't really see those things on the street anymore, but buying, what they were getting at was buying sort of fresh food, essentially. And obviously over the last 20, 30 years, there's been a move to more of us eating more processed, ready meal type food, which is really in the wrong direction.
We've just had a question from someone who's actually starting Clomid rather than IVF, and is saying a lot of what we've been talking about is, quite related to IVF. But would you say that much of this advice around diet and healthy eating, around smoking and alcohol, would that apply to anyone? I mean, even trying to conceive naturally, really?
Yes. Yeah. So I've mentioned IVF a few times because a lot of the studies have been to do with IVF, but every single thing I've said is essentially related to people who are planning to start trying to get pregnant, or who are trying to get pregnant at the moment, or who have reached the stage where they're looking at having treatment, whether that's Clomid, IUI, IVF, whatever. I mean, there's no difference with any of it.
We've had a few questions about improving egg and sperm quality, and related to that, about how long it takes for sperm to be produced and eggs to be produced. And could you just clarify that? I mean, I think you said how long for sperm? Was it 3 months?
So about 70 days, so about two and a bit months.
Okay, and what about for eggs?
Well, the difference is, though, so for men, so it's about 70 days, about 10 weeks for men. And I mean, sperm is being produced, all the time from puberty, essentially up to, obviously Charlie Chaplin was having, Mick Jagger, these guys are sort of 70s and beyond having children. So sperm production doesn't stop in men. The quality of sperm does go down in terms of the count, motility, and the volume, and the genetic quality does go down in men, absolutely, as they get older, but they keep on producing new sperm. Women are born with 2 or 3 million eggs in their ovaries. And in fact, the numbers of eggs in a woman's ovaries starts going down from before birth. So the peak number of eggs is at about 6 months in the mother's uterus. And then it starts going down. And obviously, girls aren't ovulating when they're aged, 1, 2, 3, 4, 5, 6, 7, 8. So that just shows you that eggs are not used up because of ovulation. Because if you're born with 2 or 3 million eggs and you have your menopause when there's about 1,000 eggs left, you're not having 2 or 3 million ovulations. So eggs die off just through natural cell death. It's just something that is programmed into eggs to happen. So what that means is that women's lifestyle during during their whole life, really, but particularly during their late teens, 20s, 30s, can have an effect on reproduction. And a really good example of that is smoking. So if you look at women who 35-year-old women, and you look at their ovarian reserve, so numbers of eggs in their ovaries, and you measure that using a blood test such as AMH, on average, people who have been smokers will have lower numbers of eggs in their ovaries compared to women who are non-smokers. Now, I'm sure if someone was smoking for a year or 2, or 3 or 4 years when they're in their youth, that's not something I'd worry about, but there is a link between duration and amount of smoking over a woman's life and the numbers of eggs in her ovaries.
We've actually had a couple of questions about ovarian reserve, about the different tests and whether any are better or more decisive than others. And also, is there anything that you can do to reverse to improve your ovarian reserve, I suppose?
Yeah. So there are a number of different, there are 3 main tests for ovarian reserve. The traditional test, if we were having this conversation 20 years ago, the test really is a test called FSH, or follicle stimulating hormone. So FSH is a hormone that comes from the head and goes down to the ovaries, and it sort of drives the ovaries on. So as the numbers of eggs goes down in the ovaries, the brain recognizes that, and the FSH goes up and up and up. So having a high FSH means that it's running out of eggs. Interestingly, the same is true for men. So a high FSH in men means that the brain is trying to produce sperm. It's a sign that the testes are struggling. The problem with FSH is it has to be done at certain times of the menstrual cycle. So day 2 or 3, day 2 to 5, sometime around then. The other problem with FSH is it's affected by all sorts of other hormones. So it's quite a fluctuating test. The second test that can be done for ovarian reserve is a scan, an ultrasound scan of the ovaries, looking at the number of follicles in the ovaries. And what you do is you count the number of little resting follicles, and then you have a count called the antral follicle count, or AFC. And the higher the number of little follicles in the ovaries, it gives an idea that there are a higher number of tiny little eggs that you can't see on scan, because the number of eggs in the ovaries, if it's 1 million eggs, might show up as being 15 to 20 follicles on scan, for instance, and you can count the antral follicle count. The third test, and the most accurate one, is a blood test called AMH, or anti-Müllerian hormone, that I mentioned earlier. An advantage of AMH compared to the blood test FSH is that AMH can be done any day of the cycle. It doesn't matter where you are in the menstrual cycle, and AMH comes directly from the ovaries. It's not affected by stress or other things that you're doing. So it can be done any day, and it's very, very stable. So AMH is the best test for ovarian reserve. I would say antral follicle count on scan is the second best, and FSH is the third best one.
Okay, we've had quite a few questions about, there are a number of theories about improving egg quality, about reducing exposure to toxins in your diet and taking supplements. I mean, is that evidence-based, all the stuff about toxins, or is it something that we simply don't really know enough about yet?
I mean, it depends what people mean by toxins as well, I suppose, because you can be very, very, I mean, for toxins, so tobacco smoke is a toxin. There are lots of, obviously, fumes from exhaust, the toxins. There are lots of toxins that are there that absolutely are bad generally for health, and unsurprisingly are also going to be bad for reproductive health, for eggs and sperm as well. So yes, the really obvious toxins, or people working in factories where there's not good healthcare, or sort of the safety side of it is not good, which again in the UK nowadays really shouldn't be happening. But once you start getting to toxins that people might be talking about toxins in water and saying, well, they're at high levels of whatever it might be in the tap water, or I don't know, toxins in food wrappers. And I mean, it depends on how far you push it. That's when it's difficult, because it depends what your definition of a toxin is. And often these things, really, if you had 1,000 times the dose of it, then yes, that would be bad. But the tiny dose in a food wrapper or whatever it might be is essentially not going to cause a problem at all. So sometimes I know patients will talk about, going on a detox type diet and only eating, I don't know, fruit or vegetable for a month, whatever it might be. Now, whether that's better than just eating a Mediterranean type diet with freshly grilled chicken and fish is probably fairly questionable. And there won't be any studies showing that, as far as I'm aware. But what will happen will be people may go to see a nutritionist or a dietitian, or someone who is very much coming from an area that really believes in that. And if you yourself believe in that, and that to you makes sense, that's great. It doesn't matter what I think or say. And if you feel that that's better for you, then again, that's a positive thing to do.
Thanks. I think that's a really good piece of advice, actually, because I think people get very worried about it, and we see some people leading very restricted diets and really making their lives quite miserable. I think what you're saying is, don't make your life miserable for that.
Don't make your life miserable for things that have not been shown to make a difference. There are things that you can do that will make a difference, eating healthier in a normal way, rather than very restrictive. I didn't answer the second part of your question about ovarian reserve, is whether it can be improved. I mean, by definition, you can't increase the number of eggs in the ovaries. So egg numbers only go down. It's impossible in nature to grow more eggs in the ovaries. But what can happen is you can improve your fertility by, for instance, if you're overweight, your ovarian reserve will be what it is. But by reducing weight, it may be that if you're not ovulating, you actually start to ovulate again. It may be that the Clomid or letrozole drugs or the IVF drugs work better on your lower ovarian reserve ovaries, because there's less body fat for the drugs to go around. So there are things that you can do to improve the situation, even if the ovarian reserve is low.
One thing that I think people are particularly worried about at the moment is obviously COVID. And we know that if you get COVID, it's going to delay your treatment by a while, actually. But if you get COVID when you're trying to conceive, can it also actually affect your sperm and eggs?
Very, very good question. The British Fertility Society recently updated their COVID guidance, I think just at the end of February, actually, on this. So if you go to the HFEA has got links through to it as well with information on this. there's been a lot of research in this area now looking at the effects of catching COVID on fertility. And it's very, very reassuring that there are certainly no longer term effects on fertility. If a man gets COVID and he develops a temperature from it, if a man gets a temperature due to COVID or the winter flu or whatever it is, that can affect sperm production during that 70-day cycle. So yes, COVID and being ill from COVID and maybe having a good going chest infection could temporarily affect fertility. There's not going to be any long-term effects, and it's not going to mean that the sperm is unusable. It's not going to mean that there's going to be an increased risk of problems with the baby or the pregnancy or anything at all like that. So our advice is that if a man gets COVID and it's minimal symptoms or maybe even no symptoms at all, then as soon as he has negative tests, I know we've moved away from testing in the UK now, it's fine to move into treatment or just to be trying. It's absolutely fine. For women, the same is true actually. So there's been quite a lot of stuff about maybe having COVID or having the vaccine and maybe missing a period or something afterwards. That's really just the stress effect of things just mucking up with the hormones temporarily. But there is no link between having the vaccine or COVID or having COVID on any female reproductive function. The only thing that we do need to be a bit careful of is having sedation for operations. So if a woman has COVID, and particularly if it goes to her chest, then that can mean that having the anesthetic for an operation, whether that's an egg collection or having your appendix out or whatever it might be, can be more risky. So the UK advice on this is to wait 7 weeks before having an operation after having had COVID. Now, because having an IVF egg collection, the sedation is a very light sedation compared to having your appendix out. Most clinics will say you don't need to wait 7 weeks. It's much less than that, but just be aware of it.
Thanks. We've had a quite specific question, but I think it's quite an interesting one about someone who suffers a lot with headaches, asking about taking paracetamol and whether there's anything stronger that you can take than paracetamol. I mean, in terms of painkillers generally, when you're doing IVF, what is your general advice about that?
Well, I mean, just my fertility background generally, so again, not just focusing on IVF, I think paracetamol is absolutely fine. So I think people don't need to worry about taking paracetamol before, during, after treatment and into pregnancy as well. That's not an issue. The one that people get a bit worried about sometimes is aspirin. Now, sometimes aspirin or low-dose aspirin will be prescribed to patients during fertility treatments, perhaps if there's a history of migraine with aura, or perhaps if there's a history of recurrent miscarriage, for instance, then a low dose of aspirin, 75 to 150 milligrams per day, may sometimes be suggested. Whilst we're on aspirin, there is no evidence that routinely taking aspirin improves fertility, whether natural fertility or IVF. That's been looked at loads of times over the last 20 years. No benefit of routinely taking aspirin for people who are otherwise fit and well. The third group of drugs, really, you're getting into the sort of the codeine type opiate type drugs. So obviously you can get preparations where you've got some paracetamol in there and some form of sort of codeine, cocodamol type things as well. So they're fine to take actually. So if they work for you for headaches or period pains, if people are trying to get pregnant, then taking those types of things are absolutely fine. So a bit of sort of low dose codeine type things are absolutely fine.
We've had questions about a few kind of beauty type treatments. So things like hair dye, Botox, dermal fillers, even massages. Are those things, should you put off doing that when you're having IVF or in the run up to IVF?
I mean, I think, when because obviously it's considered normal to take up to 12 months to try and get pregnant. So if people are really worried about putting things off like that when trying to get pregnant, then that's a very, very long time to go without things that you like because they make you feel better or whatever reason it is you're doing for it. Once you're getting into IVF treatment, then so when people try to get pregnant naturally, I'd say for those things it's absolutely fine. Just let the person know who's doing the procedures to you that you are trying to get pregnant. But things like hair dye and whatever obviously being tested a lot, and that's not going to be a problem. Beauty things being injected into you, I would just let the person know who's doing it that you're trying to get pregnant. And as I think probably as people are aware, there is government regulation coming in, making sure that particularly these injectable type things are going to have to be given by qualified healthcare professionals, I think for this reason, to make sure that they're being given to the right people. Now, during IVF or during treatments where drugs are being given is a bit more of a specific circumstance, because you need to make sure that these things aren't in any way cross-reacting, or that having some of these things maybe the day before having an embryo transfer put back might not be the ideal thing. I don't mean so much with hair dye, but particularly with Botox and things that are going into the circulation. My personal view would be for injectable type stuff, probably during an IVF cycle wouldn't be ideal. And I think if you can try and plan it beforehand would be better. But I could be challenged on that, because I would also completely admit there's no evidence for me to say that. So I think just being sensible.
In terms of the long and short protocol, someone's asked, is that something that will be decided by them in conjunction with the specialist, or is it something that they would just be put onto one or the other with the specialist? And does that make a difference to the kind of outcomes?
Yeah, so that's very much an IVF specific question. So if people are at the stage where they're looking at having IVF, there are two main ways of doing IVF. There's a long agonist protocol, or a short antagonist protocol. Now, in the UK, we have quite a tradition of doing a long agonist protocol. It's very common in clinics. I'm currently, as Kate knows, I'm currently in Vienna, in Austria, and the clinics over here on the continent, all of their patients have short antagonists. So there's a lot of sort of historical differences as well. The main reason for one more than the other is that a short protocol, a short antagonist protocol, has a lower risk of overstimulation, a lower risk of OHSS. So women with a high ovarian reserve, women with polycystic ovaries, younger women, high AMH, high androgen follicle count, their clinic will probably be suggesting doing a short antagonist protocol because it's safer. Women with a lower ovarian reserve, their clinics may well be suggesting doing a long protocol, but it may be that some clinics do one type of protocol for all of their patients, whether they do short for everyone or long for everyone, because they feel that in their hands it works better. The difference in terms of outcome, in terms of live birth rate, is very, very similar between the two of them. So it may be that if you're at the point of having IVF and you're aware that there's a long and short protocol, and your doctor is saying to you, okay, well, we think we should do a long or short, just ask the question, why, just so you understand the reasoning behind it. The main difference in outcome is OHSS rates rather than anything else.
Are there any specific things that people with specific conditions like endometriosis or PCOS should do before treatment in terms of preparation? I mean, are there things that actually relate to one group of patients rather than another that you might advise?
So polycystic ovarian syndrome, or PCOS, if the woman has irregular ovulations, and if she is overweight, then normalizing weight absolutely is very important, because many women will start ovulating regularly, and also normalizing weight will help the IVF drugs give more of a sort of standard response rather than a really high response or a low response. Women with endometriosis, I mean, there are things around. I know there are books and things available, sort of endometriosis type diets. Same is true for PCOS. I worked in a pelvic pain clinic for a number of years, where we had a dietitian there as part of that, and she felt that there was no specific diet that really made a difference for endometriosis, pain, and fertility. But again, if you have endo and you feel something works for you, that's more important than what someone says or doesn't say in a book. Before IVF, again, from an endo point of view, I don't think there is anything particularly you can do. It just comes back to all the general lifestyle things we spoke about.
We've had a question, which is quite interesting actually. Does it make any difference if you're preparing for a frozen embryo transfer or fresh embryo transfer? Is there anything you should do differently?
I'd say there isn't anything. Obviously, on the male side, clearly there's no sperm that's necessary during a frozen cycle if there's a male partner. On the female side, I don't think there is, because again, a lot of the stuff we've spoken about lifestyle, is also, even if the lifestyle changes may help the ovarian response, a big part of the improvement is really in whether an embryo can implant. So we know that as the body mass index goes up, there's less of a chance of an embryo implanting. Smoking is bad for embryos implanting. Excess caffeine is not going to help either. So a lot of these things are related, whether it's fresh or frozen.
We've had a couple of specific questions, one about artificial sweeteners and one about fizzy drinks. And I think sometimes those two things are kind of related. I mean, are they things that you would advise people to avoid?
So the fizzy drinks one, I think, I mean, the fact that something's carbonated doesn't matter. I always remember there was a number of years ago now, I saw one patient who had a really high BMI, and we spoke about what issues that would be, what issues that was causing for her fertility, because it was leading to irregular periods because on the background of PCOS. It turned out that she was drinking 2 liters a day of full fat Coke, of normal Coke, and really hadn't put two and two together to work out that that was or not helping her weight. So the sugar in fizzy drinks then clearly may be an issue as part of a calorie controlled trying to optimize weight. The actual chemicals in fizzy drinks or chemicals in low sugar drinks, I think for most people just drinking, if you average drinking a can a day of Diet Coke or whatever, I can't see that that's going to be causing any problem. If someone's drinking 2 liters a day of Diet Coke, okay, it's probably not causing a problem, but logically I'd be saying, well, probably be best to switch to water.
What about dairy? Someone said that they'd heard you should drink a pint of milk every day, and then they'd also heard that actually you should avoid milk. And it's kind of, I think there are a lot of things like that where people end up quite
Yeah, I
confused.
know. I think there was one clinic in London. I remember, 20 years ago, 25 years ago, was really pushing this pint a day of milk thing. I remember at the time thinking, I have no idea where that has come from. Um, I mean, this was even before the whole intralipid thing with natural kits. I don't even know where that came from beforehand, and equally, I have no idea where the avoid milk statement comes from either. And again, you probably won't be surprised to hear me say that I think it probably makes no difference. And if you feel that having a pint of milk a day is something you like doing, that's not going to be causing any problem, unless you're trying to lose weight and it's full fat milk, in which case switch to skimmed milk, I guess. But I don't think you should either be avoiding it or making yourself drink it if that's not what you want to do.
I'm aware that we're running out of time, Tim, but there's one thing I think that is probably important that we do just discuss. You did touch on it a bit earlier, which is around the COVID vaccination
Yeah.
and the secondary effects on fertility. And there have been a lot of kind of reports about people noticing differences in their cycles and things. And I think understandably that's made people quite anxious about it. I mean, is there a time that you think is the ideal time to get vaccinated if someone isn't already, or if someone hasn't had a second dose or a booster or
Yeah,
whatever?
yeah. Get vaccinated as soon as possible. So a lot of my friends, my medical school friends, are now people who are running intensive care units. They're chest physicians around the country, around the world. And when I talk to them, they all of them say that they have looked after very, very sick pregnant women who were very sick with COVID, delivering babies at 25, 30 weeks gestation, very prematurely, and very ill babies because the women were unvaccinated. In 2021, at the end of 2021, there was a report showing that all of the pregnant women in England in 2021 who ended up on ITU when pregnant because of COVID were unvaccinated. All of them. There were zero fully vaccinated women during pregnancy on ITU. And that for me, I can't understand why that isn't shown in every advert break in EastEnders, whatever, because to me, it's such a strong statistic. So get vaccinated as soon as possible. Now, I think, and Kate, before we started the webinar, we were talking about the differences, how COVID is looked at in different countries. And I was saying, I'm here in Austria, everyone's walking around with masks on, and everywhere you go, they're checking your vaccine certificates. Clinics in Denmark, nothing. I mean, there's no testing, nothing at all. And in the UK, we're moving in that way. But at the moment, the plan is still to continue with boosters, vaccines, etc. So my strong suggestion to men and women is to get vaccinated as soon as possible. If you're heading into a fertility treatment cycle, then you want to avoid catching COVID in the run up to the treatment cycle, because the current advice is if you catch COVID during an IVF cycle, the cycle should be cancelled. That's national guidance at the moment. So whether you interpret the best way of doing that as being fully isolated in the run up, or whether you're just sort of careful about it and where you go, and wearing masks or whatever, and obviously being vaccinated, is a personal decision. And I think this is where all of us need to take personal responsibility for reducing our own risk of COVID at times when it would be bad for us because of, ending up cancelling a treatment cycle.
Thanks so much, Tim. That's really good advice. And thank you for answering so many questions this evening. I'm really sorry to everyone whose questions we didn't get round to, because there were a lot of them and you had a lot of things you wanted to ask Tim this evening. But I hope we've answered at least some of your questions. Tim, I think we're just going to have to get you back another time, really.
I'll be more than happy. They're very, very good questions. And if you've got a secondary list there and in a few weeks' time you want to do this again, more than happy to.
I'm sure we'd love to come back to you another time about that. For anyone who's watching or would like to watch any of this again and catch up with anything that Tim said, it is being recorded and you'll be able to get it on our website. We record them onto our YouTube channel, and then they're all available on the webinars page on our website, so you can catch up with the webinar afterwards. And finally, I just wanted to say to all of you, thank you for so much for joining us. We are Fertility Network UK. We're your charity and we're here for you. We have a support line and an information line which are both open every day of the week, every weekday, and we're here for you to support you. We've got groups across the country and lots of specialist groups too, so anything that we can do to help you, we're here to do that. And thank you everyone so much for joining us this evening, and a special thank you to Tim. Thanks a lot and good night everyone.
Bye-bye.